Good morning. I'd like to thank you for joining us. My name is Janet Bagetta. I am the Director of the Bureau of Mental Hygiene Services Hospital and Clinic Rate Setting. Yes, it is a long name. The way you remember it is reverse alpha, the MHC. We will be doing the Q&As, but we're not going to actually read through them at the end. What we have found is that with cost report presentations, a lot of the questions are facility specific. So what we are also going to ask is that when you type in a question, also provide some type of contact information in case we need to reach out to you for more information from your question. To start, this is the agenda. Because we sent it out in advance, I'm going to save some time and not actually read through everything for the agenda and actually just get going into the presentation. Where we're going to start is our conversations with the Centers for Medicare and Medicaid Services and their data requirements and concerns. We have what's called an upper payment limit demonstration. It's a demonstration to CMS that what Medicaid pays is at or below what Medicare would pay. What we use for this demonstration in the clinic environment is a cost versus payment. So this is why the cost report is very important in this environment. The review is done on a facility-specific basis, but it actually affects the statewide. So as your facility is included in the analysis based on your specific data, it's an overall sum statewide based on these different following groups. What CMS is looking for is for us to say that there's room. They call it UPL room. And what it means is that your costs are greater than your payments. The room is the difference between there. What that room allows us to do is if there's any funding that's been provided for clinics, we can submit state plan amendments in order to get the federal funding of the approval. Without the approval of the state plan, we lose the federal funding. So this UPL room is very important. And I'm not sure if, some providers will remember very clearly that we did have issues with the 2012 UPL. We attempted to submit one. It was based on 2010 calendar year data, and that's when the concerns arose about the accuracy of the data. CMS concluded that there was no UPL room after the inclusion of the APG state plan amendments for 2012 through 2017. And the department had to withdraw 12 SPAs. So what this meant is that providers lost the federal funding of those 12 SPAs. Some of it was VAT money. So what it means is they only received the state share of the VAT money in order to do whatever their proposals were within the VAT applications. The department and CMS agreed that we would develop a corrective action plan to improve the accuracy of the data going forward. That is actually itself in a state plan amendment. Our next full UPL is required for 2017 using 2018. But if we can provide integrity of the data, we may be able to submit a UPL earlier. So this is what we're working on, and this is what drove the direction of this presentation and the changes that we made in the cost report. There were data issues that CMS raised. The big one was non-submission of cost reports. What CMS was allowing the department to do is if a provider did not submit a cost report, they allowed us to develop what was called proxy cost. Because as I stated, the UPL is the difference between the costs and the payments, and you want costs to be greater than the payments. CMS has said they will no longer allow us to develop that proxy cost. If there is no cost report, there's no cost for that facility. So that eats into a lot of room within the UPL calculation. So because of that, we really do need 100% compliance with cost report submissions. The other things they saw were things like Medicaid claims counts and eMedNI, not in agreement with the Medicaid fee-for-service visits on the cost report. The big one that was of concern was seeing the Medicaid fee-for-service claims count and eMedNI being greater than the total visits on the cost report. So that was a little alarming with seeing some of that data. The other issue they raised is that the Medicaid charge per visit should not equal the Medicaid rate. There's supposed to be a charge structure where each payer or each patient has the same charge applied. So if you're looking at your charges and your Medicaid charge per visit comes out to be your Medicaid rate, what it means is that your charge structure is your Medicaid rate. And we felt that that can't be possible because there should be a uniform charge structure across all payers, and most likely it's not your Medicaid payment that you're using as your charge structure. So to begin with some background, who is required to file? Like we said, we need 100% compliance, and who is required is all providers. It's not just a provider who has Medicaid visits, and it's not just a provider where the cost report will affect the rate. It's all providers. Our regulations are in 86.4.3. 4.3b talks about the cost report, and it talks about the audited financial statements. 86.4.4 talks about the certification of the reports. It needs to be CPA certified. However, we do have where if you're operated by units of the New York State government whose total operating costs are less than $100,000, you do not have to have it CPA certified. You still have to submit a cost report, but it does not have to be CPA certified. So that's the one exemption that we have. The other certification requirement is the CEO certification that needs to come in. In 86.4.3H, it states that the commissioner shall reduce the facility's current rate paid by state governmental agencies by 2% if you fail to file. Due to our commitment to CMS, we will need to implement that 2% penalty in order to reach the compliance that we need. Then why is it required? The upper payment limit is one that we stated that's very important for that. The other has to do with the capital component, the APG rate, or any other rate component where cost report data may be used. We are looking currently at the minimum wage survey, and we're looking at the rate calculation for minimum wage, and pieces of that rate calculation will be based on the cost report. If there's no cost report, that piece of data becomes a zero. So that will affect your payment for any type of minimum wage payment. We also use it for FQHC rate appeals. We use it in distribution calculations. We have the safety net clinic distribution and the UCP distribution. We also use it for fiscal analysis. There's state budget proposals that do come out. We are trying to look at a cost versus payment comparisons, just looking at the APG rate calculations and how they compare with cost. You also need it for certificate of need applications. The CON area reaches out to us quite often looking for cost reports. It also is needed for any data analysis review you want your provider counted. If you do not submit a cost report and we're doing an analysis, your facility is not represented in the data. So if you want to be represented, we need your cost report here. One of the other things that we get questions on is the calendar year versus the fiscal year reporting. And providers can elect to use a December 31st or a June 30th year-end for cost reporting, and that election is made at the time of the initial cost report submission. I do believe this causes confusion from some of the dual providers because the CFR, which is what is submitted for the mental hygiene services, actually works a little differently. The upstate is a calendar year, the downstate is a fiscal year, and there's two different reporting time periods. For the AHCF, the providers make the election themselves, and we also only have the cost report submitted once a year, so we don't have the different timing depending on the calendar or fiscal year reporting. For some historical information, this is actually began in 1997, Section 2807 was amended. And I did have to research that because I did not have that at the top of my head. Providers were contacted to make an election on September 2nd, 1997. So there was actually a letter that went out on that date with the request for making the election. Once the election was made, providers could not change it. Providers that open after that time period actually make the election the first time they submit their cost report. So when you begin the software, one of the things you first see is the configuration screen. This is actually the driving force of the other screens that show up within the software. So you need to go through and select the appropriate services that you want to do the reporting for. These services represent the different clinic environments. Prior to APGs, rates were set on these environments. There were group ceilings that were calculated, and even though we no longer set the rates based on these groupings, we've continued to use the same type of clinic environment settings in order to gather data. So nothing has changed in the cost reporting when it comes to the services that you will select. What's changed is the APG rate calculation and that we don't use these to set ceilings. But we do use it for data analysis, which is why we've continued with the different environments. When it comes to what do you select, what's the clinic's principal mission? That's what you need to think about when it comes to what are you choosing within this configuration screen. 86.4.3 is the old grouping reg. It provides definitions of the principal mission. So if you look at that reg, that may help assist you into what mission, what services you should select. The AHCF reports on total provider costs, that I'll talk about on the next screen. One of the things to look at is also the dually and the jointly licensed providers. If there's mental hygiene services, you report the Article 28, your 16, your 31, 32, you report them separately. If you actually look at the descriptions within the configuration screen, the ones that are the Article 28 services do not have a statement of Article 28 at the end. You will notice that there's an MMTP, it says Article 32. We have mental health, Article 31, OASIS, Article 32, OPWDD, Article 16. So that is where you would report your dually or jointly licensed provider data. Every other category is Article 28 costs get reported within that selection. The other thing I want to point out is Article 28 FQHC locations are reported under comprehensive. I have a little more to say on that on the next screen also, but that's something to remember is that the FQHC locations are comprehensive. There is a total cost requirement on the AHCF, and we've considered if we needed to continue that, but there are reasons why we have total cost. It gives us an overall look at the provider. It helps us see the primary care percentages and how that affects the provider. Capital rates were historically developed on total provider clinic capital costs. We did submit a state plan amendment, it was 1559, and it was submitted to use Article 28 capital costs only. With the withdrawal of the state plan amendments that had to occur when we did not have UPL room, CMS did not require us to withdraw this SPA because it was APG related. So this is still an outstanding SPA. It goes back to 1/1/2016 rates. In October of 2015, we did send out a notice to providers making them aware of the capital calculation and that it was changing. And as of yesterday, I did receive a question from CMS regarding this SPA. So it is being looked at. And we're hoping, that we can get this approved soon. I am noticing someone commented saying phone went dead. Okay, I'm being told technically no, we're still okay. When it comes to federally qualified health centers, OMH and OASIS use the DOH calculated FQHC rate. So it's part of the reason why we also need total costs. During the discussions that we've had with CMS, they asked us if we had the ability to separate FQHC locations and non-FQHC locations, because you can have a provider that has both. The non-FQHC locations should be included in the UPL calculation. Because of the way the cost report is reported, we have everything combined as one. So we do not have the ability to separate the FQHC locations and non-FQHC locations within one clinic's cost report. So that is something yet to come. We have to think through how we would actually approach that within the cost report, and we're looking at it for the 2017 cost report if we can get the right concept as to what we need to do for programming. One of the things to point out is that, as I stated before, the Article 28 FQHC locations are comprehensive. If your principal mission for all the locations is comprehensive, that's where you don't have the ability to split out the FQHC and non-FQHC locations. However, we do have some FQHCs that are UCPs, and they have the ability to actually select comprehensive for the FQHC, and then they can also select developmentally disabled for the non-FQHC locations. So there is an ability to split out the FQHC locations and non if your principal mission is something other than comprehensive. So that is just a technical thing that we did want to point out, is there is that ability to split them out as long as the mission is not comprehensive for all locations. So that's the cost. Question comes in, how do you report the utilization? We met with CMS and we analyzed the rate codes that are in the UPL. And what we needed to do was accommodate for these rate codes in the cost report. Because if you think about what they're picking up based on the utilization from eMedNY, it's based on these rate codes. So if you're looking at, one of the issues was the data comparisons. You're looking at the comparison of the Medicaid fee-for-service in comparison to the total visits on the cost report. So they're pulling the Medicaid from these rate codes. We need to accommodate the same services within the cost report. These here are the DOH only. There are many other mental hygiene rate codes that are used, but the only thing we put in the presentation was the DOH ones that we actually looked at. For the 2016 cost report changes, we had to take a step back and say, what do we need to do within this report? What's the requirements that we need to have? We needed to develop a visit screen that will accommodate all services. Because if you think about the way the configuration screen works, when you click on it, you get the same exhibit for every single service. It's just the header is different. So we had to devise a screen that actually would work for all the services. We also needed to be able to calculate an appropriate capital rate. Not all rate codes pay capital, so we need to be able to do that. We also needed to provide appropriate data for the UPL. So these were the three requirements that we had on ourselves in order to develop the cost report changes. So this is what we've done. On Exhibit 1C, that's the statistics for patient care. That is where you will see the largest change. We detailed patient services between capital and non-capital related, because like I said, not all rate codes pay capital. On 1D, because of the changes we did on 1C, we did not have to make any changes to the visits or procedures on 1D. We did make a slight change on there to collect some distribution payments. When it comes to the cost by service, we eliminated the ability to remove the school-based health centers cost from the total cost. There was always an adjustment that was allowed to be done. That has been shaded. In 2017, we will completely eliminate it. We adjusted the formula for capital, so it uses the appropriate capital visits And on the statement of revenue, we have those same distribution payments that we had to incorporate. So start drilling down on Exhibit 1.3 or 1C. We had some revised headers in order for clarification. We moved the school-based health center between sections because the school-based health centers do receive a full APG payment plus capital. So we moved them on the screen. We enhanced Section 3. That is where you detail all the different services. And I'll go through the screens, so I'm not going to read through them. I think it gets a little confusing to read through them without seeing the screens. We have a new row for the total visits, including OASIS. That'll make more sense as we go through the screens. And then Section 4 with the procedures, we actually added a row for ambulatory surgery. There was never a place within the procedures for ambulatory surgery to report the procedures. They were putting them under the other. So we actually have hard-coded a row for the AmSurg. So to start with the first section of Exhibit 1C, there's very little changes within the first area. You'll see the total number of users, the total number of threshold visits, and then we have the off-site visits. This is where we move school-based out of off-site, and there is an edit within here because you will actually type the total number of the threshold visits, and that will tie into the next screen. So basically, these are small changes within the first section. When it comes to up on top, we have it coded as name of service. Once you select from the configuration screen, whatever you selected becomes the header. And this is where I said we had to accommodate a visit exhibit that would work for all services because each service has the same rows, and the headers on it. So the columns had to work for them also. Within Section 3, this is where we did some more movement around. We revised the header for dental. Mobile dental unit had been put under the other. It really can be combined under the dental. We moved into this area, the school-based health centers, and we pulled out the methadone dispensing. There's not a lot of changes within this section, but this section is what we're using to develop the capital rate, which is why the methadone dispensing had to come out and the school-based had to go in, because line 25 is going to be used for your total visits for your capital rate development. If you were looking at this for the Article 28 comprehensive, you could be filling in all the patient care services that you have within the Article 28. If you're using this and what you selected on the configuration screen, say for example with the mental health Article 31, you wouldn't have all the patient care information filled in. It would most likely fall mainly under the mental health rows. So the screen will accommodate for the mental health with the configuration screen of the mental health. And like I said, this is where you have to remember when you select on the configuration screen, this same exhibit pops up for all the services, but you only want to detail within the lines the information that corresponds to the service that you're reporting for. Then there's a new section. And within this section are the services that don't have a capital rate calculation. So we've separated between the first section that will be used for the capital rate and the second section that will not be. However, we need to capture all these visits in order to tie to what CMS is looking at with the rate codes. So that's what we've detailed here. So you'll notice that these are all new rows, new sections, new formulas. And what we've also then done is we've pulled out the OASIS from those other visits in order to keep being separate. But we're still collecting the data for total facility. So in the end, we have row 052, which is your total visits. It's your total facility visits, including all your duals and jointly licensed services. So if you summed up the 052 for all the columns you selected on the configuration screen, that comes back to your total facility visits. The last section, very minor changes. Like I said, we added the ambulatory surgery. So there's also the line 035, and the 035 is your total procedures. I do have another edit screen on here where I'll talk about these edits that are noted on here also. So we'll look at them in a little bit more detail, but it basically crosses this exhibit to the by-payer exhibits. So when it comes to Exhibit 1C, the main change is splitting between services that are part of the capital rate development and services that are not, trying to capture all the data that CMS is looking at when they pull claims from the eMedNey payment system and they say these are your total Medicaid visits. We have something comparable within the cost report that matches those same services. As I said before, there were some other small changes that we had to do when it comes to the distributions. We now have the clinic safety net distribution. Providers have received some VAT funding. There's also district funding. So we've just made lines to accommodate for collecting that data. In the cost, as I stated before, the school-based health centers costs used to be adjusted out. We are no longer adjusting them out because they should be included because they receive a full APG payment and a capital payment. So they are now included. The visits are included in the capital calculation. In 2017, we'll actually eliminate the column, but because of timing, we didn't want to go through the removal of the column because that would have taken longer even to get the programming done. When it comes to the threshold visits, this is all from the instructions. So the information here is not something that isn't available already. As I stated before, we designed the Exhibit 1C to separate the visits. And what we're hoping it also does is provide some clarification as to, is this a threshold visit or is it not? Because we're hoping that by splitting out the two sections, that you will see where you need to report the utilization. So that was something that, like I said, we're hoping with separating the sections, providers can say, okay, you know, we have a vaccine, this is where it needs to be reported in the non-capital section. We didn't have that ability before, and if that information was reported in the threshold visits, it did affect the APG capital rate. So as I said, I'm not going to read this screen because this is in the instructions, but this is what we're hoping within the change to the cost report itself will help drive the ability to figure out where to report the visits in the software. When it comes to procedures, if you included them as procedures, do not report the visits because they end up counted twice then. So if you are required to report procedures, only report procedures. And for reimbursement purposes, all the visits related to the procedure, regardless of the number of visits, are counted as one procedure. So you would basically have a pre-visit, the actual procedure, and a post-visit. And that is your procedure, and that counts as one. When it comes to reporting OTP, which was formerly MMTP, what we are looking to be reported are the daily visits. So if you have 5 daily visits in 1 week, report the 5. Don't report 1 visit. You need to report the 5 daily visits. So that's what we're looking for within the OTP reporting. When it comes to ordered ambulatory, this information is also in the instructions. However, we're in discussions with CMS as to how to approach the ordered ambulatory within the UPL. So we don't have any determination set for exactly how we approach it in the UPL, but what we're trying to do is get consistent reporting within the cost report. So as we're working through the discussions with CMS, we know what data we have. So when it comes to the ordered ambulatory, it is a non-registered clinic patient, cannot be billed using the clinic rate. When you submit an APG claim, you need to use the U6 modifier if you want to be paid or not. And the visits are not included as threshold visits. There is a separate area to report them on 1D. And the costs associated with these must be removed from the operating costs. So this is the requirement of how to report it, and this isn't any different than what has been done in the past. But if we have consistent reporting, like I said, we know what data we have as we work through the discussions with CMS. When it comes to the data edits, we referenced them on the other screens, but this is what you're actually doing with those data edits. On 1C, on line 2A, you actually manually type in the number of threshold visits. But then for line 25, it's going to sum up all the patient care. So the number you put in 2A, you've now split between all the patient care centers. So we have an edit in the software that just makes sure that those two numbers are in agreement. When it comes to Exhibit 1C and 1D, 1C is the patient care services. The other is the visits by payer. We need totals on both screens to agree. So on 1C, we're using line 52. On 1D, we're using the visits column, line 960. Those two are being edited to make sure that they're in agreement. The cost report fee-for-service Medicaid reported visits on Exhibit 1D should equal the eMedNI claims count. So if you look at all those rate codes that we said are used in the UPL, that's the Medicaid number that should be showing up on 1D. Works the same with the procedures. We're editing between the patient care services and the total procedures by payer. And the Medicaid reported procedures should equal your eMedNI. So if you're looking at what's reported on 1D, that should be your total procedures, your total visits. And that should tie back to all those rate codes that we're showing you that are being used in the UPL. So that's how we've designed it, so that when we are pulling from the cost report your Medicaid utilization, and then we're pulling from eMedNI the Medicaid utilization, those two numbers should be in agreement, because that's what CMS is looking for. The other thing we're hoping that it provides is if we've now accurately captured the Medicaid utilization within the cost report, that the Medicaid claims in eMedNI will not be more than your total claims in the cost report. So this is, like I said, the goal that we were shooting for based on getting the appropriate data within the cost report. So now the timing, and you'll notice that there aren't any dates on here yet. We are very, very close. But one of the things we're going to do is start with a 2015 survey. 2015 cost reports are in, but if we can provide good data to CMS, there's a possibility of completing a UPL earlier than 2018. We are working with the mental hygiene staff and the UPL staff, because we're trying to coordinate this through all the clinic providers that are incorporated into the UPL, because the UPL is not DOH only. It's all the mental hygiene services also, their clinic environments. We're going to be going out with a survey. It's the same design as the minimum wage. It was done in Survey Gizmo. There was supposed to be a meeting yesterday that would let me know if I have the green light to go with this. However, it was moved to this afternoon, which is why I could not change the screen and let you know what the dates are on this and when it's a go. So I'm hoping to have some further information this afternoon. We are ready with the survey. We just don't have the approval to release yet and move forward with it. We will be providing 2 weeks to complete it. One of the things that you can begin doing is looking at your 2015 data. It may also help you in developing the 2016. If you look at your 2015 and see how maybe it would have been reported differently if there had been an expanded Exhibit 1C, how would you have reported your 2015 data? We will be using this survey for this purpose only. We're not going to use it in rate developments. We're not going to use it to recast any distributions that are already done. The purpose is for the UPL. When it comes to the cost, that's not part of the survey. The only thing we really need is the revised visits. The cost should already have been reported. You should have reported total facility cost. Even on the cost report, we require you to exclude the school-based, but you actually adjusted it out. So we have the numbers adjusting it out so we can add back. So we didn't need to do anything for the cost for this purpose, but it's mainly the visits, and it's using the new Exhibit 1C format. The 2016 software release, it is in development. We are very close. There was one small issue that was found in testing that we're waiting to get back from our programmers in order to test and see if it's clean. So since we want to start with the 2015 survey, even if the 2016 software is ready, we are going to release it. But if we are asking 2 weeks for the survey, then we will expand that 60 days from release of the survey to include 2 weeks. But if we're ready with the software and a provider is done with their 2015 survey and ready to move into 2016, we don't want to delay the release of the software just waiting for the deadline of the 2015 survey. So the release of it could overlap, but we will accommodate the time and the due date. We will also take into consideration the upcoming holidays. We do know that we have Christmas and New Year's coming up, so we will consider that in the timing when it comes to that 60 days from release. Like I said, you can begin developing your data, hopefully based on what we've provided in this presentation, because you can see the rows that have been added, the expansion of the data. What we gave you in the screenshots is actually our specs that we sent to the programmers. So you can see what it is we requested for them to do. So hopefully that will provide you the ability to begin moving forward in looking at your data. So just some other housekeeping stuff is accessing the software. You need the HCS account in order to be able to do that. We use the HCS as a communication tool. That's actually how we email blasted everything to do with this presentation. So we use who has access to the DNTC cost report within the HCS. You need to keep email addresses current, because like I said, if we're doing the email blast using it, it's the provider's responsibility to keep those emails accurate, because the department cannot go in and make the change. That has to be done by the clinic. There is a separate email blast based on the public website, and I'll go into that a little later. The other thing you need to do is the removal of an employee when they leave employment. If you don't have them removed, if you don't contact the HCS environment and have the person's account removed, they still have access to the information. So just because they left your employment doesn't mean that they don't have access anymore. The HCS is the secure network. We post facility-specific information there. This is where the software is for download and upload, the rate sheets for APGs and capital, and the FQHC, and then the distribution calculation. So we put that information up on the HCS. So it's very important for a provider to keep that current. As I said, you need the HCS account to get the software. This bureau cannot establish the HCS account. The accounts are person-specific, not provider-specific. So that's, like I said, if you have an employee that left, it was a person-specific account, not your clinic-specific. So they left with their account. So there's security issues also if you are sharing accounts, because it is, like I said, person-specific. Providers have an HCS coordinator, can set up an account. You can do it online. New providers, if you have no coordinator, there's a telephone number to contact for CAMO, and they can work through and get the accounts established. Even if you have an HCS account, you still do not have access to the AHCF Cost Report application on the HCS. So there's an access application form that needs to be completed. So the first step is to have an HCS account, then you have to get access to the application within the HCS. So the HCS account opens the door to get you into the HCS. The access application gets you access into the specific applications. We've provided the information how to retrieve the access application form. The signatures must be notarized. Once it's done, you can email the completed form to our DNTC unit email account. You don't have to hard copy send it, an email is fine. The cost report document filing requirements. We need not just the electronic cost report using the HCS, we need that CEO certification, the CPA certification, and the audited financial statements. The CEO and the CPA are the first pages of the AHCF. You need to print them and complete them, and we don't accept alternative certification forms. One of the things that we're pointing out here in bold is that a complete submission includes all four. If you have not submitted the CEO, CPA, and the audited financial statements, you don't have a complete submission. So it's very important to remember that those documents have to come in also. When should those documents be submitted? 5 business days after you submit your electronic report. You can submit them by email, same DTC unit email account. The subject line, please put the 2016 AHCF documentation and the name of your facility. We used to require hard copy submissions. We no longer require them. So everything is emailed PDF format, and that is the naming convention that we are requesting. By putting them in that specific naming convention, it helps us with sorting and organizing and getting everything stored. There is an APG website. This is the public website. It provides contact information, and it also includes the O-agency's contact information. So if you have questions regarding APG rates in that environment, there's also that contact information. It provides both APG and FQHC information. So there's actually a screen for the FQHC, and it has the ceilings and other information for FQHCs. It is another method for us to communicate with providers. When we do an update to this website, we email blast everybody who has subscribed to the electronic mailing list. So if you go in and you subscribe to the electronic mailing list, every time we do an update to the website, we will email blast out specifically stating what it is we updated on the website. This presentation, a recording, and the Q&As will be posted on that website. When they are posted, we will be doing an email blast using that electronic mailing list and letting you know that it's available. So what we do ask providers to subscribe to that mailing list because it's good information for them. These are the contacts, that same DTC unit email account, and the staff does go in every day and monitor it. Please identify yourself in the email by your name, the name of the facility, the operating certificate number. Sometimes the names of facilities are very close, so if you provide your operating certificate number, we can detail exactly which facility it is, and also a telephone number for contact. If there's any problems with the electronic submission, there's an AHCF helpline. We do not get involved in the electronic submission of the report through the AHCF. And there's that DTC email account again. Like I said, it's very informative, not just for the DNTC cost report, but any other questions you have regarding distributions, rates, and they're very helpful. As I stated before, the Q&As will be posted. We will go through them, and if we have questions on, on your question, we have the ability to contact you. When we post the Q&As, we will be removing the specific information for the person. So your name, your contact information will not be in the Q&A document that gets posted. The presentation, it was email blasted out, so hopefully people had it prior to this presentation. But like I said, it will be posted on the public website if you didn't receive it through the email blast. So once we get it posted, we will send out an email based on the subscribers to the website. I do want to thank everybody for joining, and again, thank you for your patience. I know that, our intent was to have this presentation some time ago, but as you can tell, we've worked through a bunch of details when it comes to CMS. We do hope that it was informative, and we do hope that the data changes that we've made will provide to CMS what we need in order to get a UPL approved for the future of making changes to the rates. Thank you.